Just change the background there because for some reason it should look really dark.
We both went to Leeds, so we both sat the ostomy and the Leeds. Multiple choice.
Yeah. So I'm not going to read these out, so I'm pretty sure you can all read. But we're just going to talk to you just a little bit background on PEs and DVTs, and then the important bit for you is like how you diagnose it and how you manage it. So a VTE, venous thromboembolism, is anything from a DVT to a PE, and it's a spectrum. So if you hear anyone talking about VTE, that's what they mean. It is a multifactorial prothrombotic state, so anything that is going to stimulate your blood to form clots can be a cause of DVT and PE. But it's based, if you remember back to your pathology, like second year, that's based on Burgos triad. That's just a little pretty picture for you there. So it's just changes in the vessel wall, changes in blood flow, changes in constituents, and in brackets you can just see the causes of these. You don't need to worry too much about this. The reason why I put it on is that you just need to know basically that clots can be formed by the intrinsic or extrinsic coagulation pathways, and these are important clinically. So warfarin acts on the extrinsic and heparin acts on the intrinsic. And we measure warfarin with the INR, or you can actually measure the prothrombin time as another method of measuring extrinsic pathway. And the APTT and the APTT ratio we can use to work out the intrinsic pathway. So this Venn diagram here just shows you all the different risk factors that can cause you to have a VTE. But roughly speaking, we can group these into major and minor risk factors. Things like obesity, there's a lot of crossover, and it depends on what you read really, as to whether it's a major risk factor or a minor risk factor. The main things are anything that causes a trauma to the vessel, or conditions that can cause you to cause things like thrombophilia or other bits and pieces. Yeah.
When you say that thrombophilia is a minor risk factor, is that because it's not very common? Because surely someone's got thrombophilia, it's a major risk factor.
Yeah. So it's more that it's not, with regards to general population, it's not as common. Obviously, the people that do have thrombophilia and they have major risk factors on top of that, or even minor risk factors, they're going to clot a lot easier than you or I that don't have that.
The majority of people that you'll come across that have a DVT or PE will be because they're immobile, had recent surgery, or because they've got an underlying malignancy that either has been diagnosed and they've just had a clot, or is actually undiagnosed, and a clot will be the first presentation.
So it's really important because a PE is one of your reversible causes. Remember from like fourth year, the 8 reversible causes of cardiac arrest. So a PE is one of them. It accounts to about 25,000 deaths annually, but actually it's probably more than this. This is just what we know of. Leading cause of morbidity and mortality in hospital patients, like Sophie was saying, particularly surgical patients or medical patients, especially elderly that have been in bed for quite a long time and have not had like VTE prophylaxis, are at risk. If you don't actually treat DVTs, about 90% of them progress to a PE, so it is really important that you get on top of that and treat it. And there is always a risk of recurrence, so it's kind of increases exponentially. If you have one clot, then you're at risk of forming another and another and another, because you get this kind of prothrombotic state going on within your own vasculature.
Okay, so DVT, deep vein thrombosis. So some of the presenting features, so a lot of people actually are completely asymptomatic when they have a DVT. The main one we're going to talk about is leg, because that's the most common, but you can also get them in your arms as well, especially people that have PICC lines seem to get them. You can also get them in other areas of the body, but legs are the most common. Obviously pain that can present with tender, swollen, red calf. Sometimes they present with features of PE, so short of breath or hypoxic. So on examination, you find tenderness, swollen calf. I've never actually seen anyone measure a calf, to be honest with you. I don't think you find tape measures on wards very often. But you can normally tell that one leg is swollen, very painful. You can see superficial veins. You get Holland sign as well, which is pain on dorsiflexion of the foot. And you can, the picture's just going over it, but there's a very rare complication from DVT that I can't pronounce, but I think it's phlegmasia cellulodollens. It's essentially when you get a blood clot that completely obstructs the vein, and you get cyanotic discoloration, massive edema, and you can get gangrene if it's untreated. It's mainly the ileum.
So with the Homan sign, are you not supposed to do that in case it causes a clot to come off for the OSCE? I don't know.
To be honest, I've never done it. I've never needed to. If someone's got a tender painful cough, you get an ultrasound of it. But it's in all the textbooks. It's one of those indicator signs, but it has its limitations because if you have any lesion in the calf, it will get a positive response. So it's not diagnostic of DVT, and you shouldn't really need to use it to make a diagnosis or make you decide to get an ultrasound scan. It's just something in case you get asked in the OSCE. It's just a sign. Okay, so just a little bit of anatomy, not much advice. The majority of DVTs occur in the calf. The distal DVTs often don't have any symptoms and are thought to actually resolve spontaneously, although obviously it's not the case in everyone. But it's the proximal DVTs that are most often symptomatic ones. Okay, so just some quick DVT facts. About half patients with symptomatic DVTs, if it's left untreated, they will develop a PE within 3 months. So that's quite a large proportion of people with DVTs. So if you can treat it, so preventing them from having a possibly fatal episode. And these were facts actually that I found that I didn't know at all. So before the days of routinely prescribing tisaparin or enoxaparin, half of patients that had a prostatectomy would develop DVT, as well as half of patients that had a cerebrovascular event develop DVT. And about 10 patients that had a heart attack could also be found to have a DVT as well. Okay, so clinical diagnosis by itself is unreliable because lots of conditions can mimic DVT, such as cellulitis, ruptured Baker's cyst, hematoma. They're just some of the ones that can cause it, which is why we have the modified Wells score, which is what you should use to assess the likeness of DVT. Okay, so you've got all of the criteria there on the right. Essentially, if anybody gets a score less than 2, you should do a D dimer. If the D dimer comes back as raised or positive, then they should have an ultrasound. So clinical symptoms with a D dimer have got a combined sensitivity of about 80%. And if you've got a Wells score of more than 2, then you should have an ultrasound and a D dimer. And the reason why they actually say you should have a D dimer as well as an ultrasound is that an ultrasound doesn't always pick up the blood clot. Most of the time it will, but if you come back with a negative ultrasound and you've got a positive D dimer, you can't really say they definitely don't have the DVT. It's definitely worth thinking about it and bringing them on. If you really have a strong clinical suspicion, treating them for the DVT, you can always come with the ultrasound in a couple of days' time. So much up then. And see, as you can see, the sensitivity can vary massively for detecting DVTs depending on where it is in the bed. Having said that, D-dimer is of very limited use. You can get lots of false positives. So it's non-specific to DVT. Lots of things can cause it. So any kind of inflammatory response from surgery or strokes, infections, malignancy, they'll all produce a false positive D-dimer. And again, the other ones as well, although it's not actually that common, but you can get false negatives. So if you've got a really, really small blood clot, that will get a negative D-dimer. And if you leave it a long time between getting to the lab, it can go in the sample as well. Okay, so management of DVT. The main thing we're trying to do with DVT is prevent it from progressing to a PE. So if they're estimated, you'll put that on my GFR, sorry, is over 30, then you should treat with tisaparin, 175 units per kilogram. If it's less than that, then you do enoxaparin 1.5 milligrams per kilogram. And what you should do is you should treat them, I think guidelines say it's 5 days, but realistically you treat them until you put them on warfarin and the ionized therapeutic, so that'll be 2 to 3. And obviously if it's your first DVT, it'll be 3 to 6 months. I think it varies from place to place. I was always taught that if it's below the knee, it's 3 months treatment with warfarin. If it's above the knee, it's 6 months treatment with warfarin. But I think it does actually depend on the clinicians, to be honest. And if it's your second or recurrent DVT, it should be on like warfarin.
So do you want the INR to be the standard between 2 and 3?
Yeah.
It's the same as...
So yeah, in terms of symptoms for a PE, you'll quickly learn that it's quite non-specific. The things that I've highlighted here in red are things that they all usually have. Shortness of breath, pleurisy, chest pain, tachycardia. Having said that, they may not have a tachycardia. They might just be a bit breathless, or they might just have a bit of chest pain, particularly in sort of elderly patients. Chest pain might be the only thing. So it's something to just keep in the back of your mind, even if they say they've got like left-sided chest pain, central chest pain, just keep it in your mind that it could be a PE. Things to look out for as well, you can, when you're assessing clinically, they might have a raised JVP. You might hear a bit of a pleural rub, but chances are the chest sample will be quite clear. There are signs like right ventricular heave, and what that is a sign of right heart strain. Because if you've got a clot there, it's going to put pressure on the heart, and you get like a backlog. You may feel it, you may not. And always look for signs of a DVT if you're suspecting PE in someone, because chances are you might see that actually they've got a red hot swollen leg, or they may not, but they may have had that maybe 3-4 weeks ago, but forget to mention that when you take in a history. It's amazing what patients won't tell you, not through any fault of their own, it's just that sometimes they forget, or they don't think it's relevant. So how do you think you would probably approach someone with if you thought they're a bit breathless and you get a bleed and the nurse is like, oh, you can review bed for breathless?
PBCD.
Brilliant. ABCDE, so we're going to do that to death, but literally if you remember that for your OSCE, and actually when you start work you'll be absolutely fine because it's not any more complicated than that. If you can, I've got history at the beginning. Obviously we'll do an ABCDE assessment if someone is acutely unwell, but if they're just sort of a little bit breathless and you can gauge that they're actually talking to you, it's good to ask them questions while you're sort of doing your assessment. But the main things to look out for are, with the airway, if they're speaking to you, it's fine, move on to B. If you can hear a wheeze or a stride, or you're in any ways worried about that airway, crash call your seniors, because you're probably going to need an anaesthetist if they lose that airway. Look for the respiratory rate, look for signs of sort of struggle, so accessory muscle use. Always, people will vary with what they tell you, but as a general rule, if they're sort of stable and their blood pressure's not in their boots, sit them up, non-rebreathe mask, 15 litres. Sometimes you might have people telling you that actually COPD patients it's not good to do that, but in the initial setting, hypoxia will kill them quicker. And you can buy yourself a few minutes. Check the fluid balance status, assess for tachycardia, hypertension. If they are hypertensive and tachycardic, fluid challenge is not going to hurt. Assess the GCS. I've put on here urine dip, query, DK. If they're struggling with their breathing, it's always something just to keep in the back of your mind. Examine them. Any information you can get, relatives, friends, A&E notes, paramedics, GP, use it. And if you're thinking it is a PE, then you really need to get your seniors involved. Investigation-wise, bloods, I've put troponin on here. It's really more of an exclusion diagnosis than you actually thinking that they've had an MI. And it's just something to remember to do in anyone with chest pain. ABG-wise, usually doesn't really show much. It might be a bit hypoxic, but usually the CO2 is normal. ECG findings, we'll go through that in a minute, but it's anything that shows, like I said, right ventricular strain. Chest x-ray is usually largely normal, but you may get an effusion. And echo, some hospitals like to do it. I don't think they really do it that much in Leeds, but you can get like a bedside echo. Sometimes that can be of value. Okay, so Signs of a PE. This ECG doesn't show it, but you have to bear with me that not particularly this ECG, but most patients will have tachycardia. Does anyone know what this shows, the red arrows? Yep. Right axis deviation, and you look at leads 1 and leads 3 for that. Some people say leads 1 and lead 2, but lead 1 and 3 I usually look at. Anyone know what this is? If I said you can see it in V1 and V6.
Right,
Yeah, so the marrow and milieu. Remember that? This. In leads V1 to V4. Two inversion, yep, so the signs of ischemia. And finally this. Does anyone know what this is? Yeah, I think I heard a Q wave somewhere. Anything else? Yeah, I think I hear it muttered, so that S1Q3 T3 business that you sometimes hear people talking about with ECGs. You actually only see this in about 10% of PEs, but it's just something to keep in your mind that they might stick it in the slideshow if it's a very obvious PE and you get like an ECG, just have a quick look for it. But yeah, you get an S wave in lead 1 and you get a Q wave and an inverted T wave in lead 3. Does anyone know what this is? Shall we be experts now after that first lecture that you had? Left side confusion. Yeah. So you might see this. How about this? Yep, I heard someone say it's normal. So yeah, I would say probably 99.9% of the time that's what you'll see. So chest X-ray is not very specific. It's more of a diagnosis of exclusion, so it's just to rule out a pneumonia, basically.
Thorax.
You know what this is? Just the test in general. Echo, yeah. And that says it on there, mobile mass. So that's a natural clot before it becomes a pulmonary embolism. So it's in transit. Okay. It's unlikely that you'll get anything like this in this slideshow, but I've just popped it in for completeness. Okay, so you assess PE in exactly the same way that you do a DVT, but you use the 2-level PE well score as opposed to the DVT score, and this is what it is. But the important points are, if it's more than 4, you need to do a CTPA. If it's less than 4, you do a D-dimer. If the D-dimer is raised, then you do a CTPA. The thing to mention about D-dimer is it's very non-specific. So in someone with acute breathlessness, the D-dimer can go up if they've had a PE, it can go up if they've got a pneumonia, it can go up in heart failure. So it's quite non-specific. So you need to put it together with the clinical picture. If you think someone has definitely had a PE, so I don't know, 4 days post-op, they've got a leg swelling, they're very breathless, they're tachycardic, but you know the score's about 4, but you're pretty sure, then I would go straight ahead and do a CTPA. And that's really all this says. A VQ scan is a scan that you do, and it looks at ventilation and perfusion in the lungs. And what you do is the patient inhales like a radioactive isotope, and that's also injected. And then what they do is they take measurements and they look at the distribution of ventilation and perfusion in the lung. And if there's a mismatch, i.e. there's an area of the lung that's being ventilated but not being perfused, it's pretty obvious that there's a clot there. And that's how they diagnose a PE on the VQ scan. I've put it in here. Most hospitals now do CTPAs, and you need to get an immediate CTPA before you start treatment. If you can't get an immediate CTPA, you start treatment, and then you need to get a CTPA within 24 hours.
Does anyone know why you do a VQ-VT scan rather than a CTPA?
Like a woman of childbearing age?
Yeah.
As a contrast.
It's Or if they're allergic to contrast, but yeah, if they're pregnant as well, they tend to do a leaky VT, or they can sometimes do a half contrast CTPA.
And yeah, like I said, if the P is unlikely, you do a D-dimer. But if that's really high, in addition to the clinical picture, then you need to do CTPA. But if the D-dimer is negative, and they've only got a Wells score of 2, then it's probably likely that they haven't had a PE, so you don't need to do anything else. Unless you suspect a DVT, in which case you need to treat that. Anyone know what this is? CTPA, yeah. So PA is pulmonary artery, A is the aorta, and that actually is a saddle embolus. So that kind of sits in the middle of both of them, and that's really, really bad. And we'll talk about management of that in a second. But yeah, you definitely need to get rid of that clot. And that's just a coronal view, the same thing. Does everyone know what CTPA is? CT, pulmonary angiogram. So yeah, it's just contrast CT that looks at the vasculature in the lungs. And this, I'm going to hazard a guess. Yes, VQs now. Okay, so management-wise, I've got this up in red. This is the first thing you need to do, and you will be doing this when you do your VTE assessment. Once you've done your CTPA, you need to think about what you need to do then. If they're hemodynamically stable, so they're a bit tachycardic, but the blood pressure's holding and everything else looks okay, essentially they don't look like they're about to arrest, you need to start an anticoagulant. And there's different, depending upon the trust that you work in, there's different ones that you can use. It's usually a low molecular weight heparin for most people, unless they're at risk of bleeding, they're elderly, or they've got renal function, basically. Low molecular weight heparin is usually 1.5 milligrams per kilogram or 175 units. Exactly the same dosage. You'll just see it written in different ways. You need to then start warfarin as soon as possible. But because of the actions of warfarin and low molecular weight heparin, they kind of cancel each other out. So initially, warfarin has a pro-clotting effect, which you think is a bit odd considering it's an anticoagulant. So that's why you have to continue the low molecular weight heparin whilst you start the warfarin until you get it within target range, and that's 2 to 3. And it's usually between sort of 2 and 5 days, depending upon the patient. If on day 2 they're INRs 2, that's absolutely fine, you can stop the warfarin. You just need to make sure that it's been at 2 for at least 24 hours. If they're unstable, however, chances are they probably wouldn't have even had a CTPA. It'd probably be a clinical diagnosis. But say you did the CTPA and then suddenly they became really unstable. The blood pressure was like 80 over 40, they were tachycardic. Essentially, you thought they were going to arrest. This is when you need to consider thrombolysis. But don't worry, as an FY1, that wouldn't be you making that decision. It would definitely be the seniors. So that's why it's important to make sure that they're aware when you suspect a PE in general. But just for your learning purposes, you wouldn't be expected to know the dosages of thrombolysis or anything like that for your exams, but it's just so that you know what it is. The most common ones we use are alteplase and streptokinase, and there's an actual hospital protocol for how you give it and when you give it. But I think it's actually the respiratory people that do it, or vascular, so you wouldn't have to, you just have to make that decision that actually I think they might need.
FY1s would never be expected to give it as a registrar. It was a respiratory anyway, registrars did it.
Yeah. So yeah, in terms of that, the only thing you need to know is the dosage of low molecular weight heparin. There's different types of low molecular weight heparin. You don't really need to worry too much about this. I'll just put it in just so you've got a bit of an idea about the different types. Enoxaparin is Clexane, that's its trade name. In Leeds, we use tinzaparin for most patients, like Sophie said, unless they're really impaired or very elderly, and then we use enoxaparin. They used alteparin in Pinderfields, just in case any of you are there or end up working there. You can give fondaparin as well, and that works in a very similar way to low molecular weight heparin. It won't work on factor 10, so I've just shoved that in for completeness. And and you have a lower rate of heparin-induced thrombocytopenia, so low platelets, because there's a risk when you give heparin that you're going to wipe out your platelets. Low molecular weight heparin does this to a lesser extent, so that's why we give it as well. It's safer. But you can give unfractionated heparin. There's a protocol, and I'll show you that in a second, for how you give it and when you give it. Again, you're not going to need to know dosages or anything like that. You're not going to be expected to do it at all. I just put it in so that you're aware that we also give that. We tend to give it again in renal failure, and we give it in patients that are at risk of bleeding. So kind of post-op, if they're thinking that the surgeons might need to take it back to theatre, we usually give unfractionated heparin because you can reverse it within about half an hour with protamine. You give it by an infusion or you can bolus it, but again, you wouldn't have to give it. There's other different methods. Medical and surgical embolectomy, again, you don't need to know anything about this, just be aware that there are other methods. That's usually the vascular surgeons or the interventional radiologists. It's, again, nothing to do with you. And there are also filters that they tend to give in patients that have cancers or recurrent PEs and DVTs where anticoagulation hasn't worked. So this is a heparin infusion chart in Leeds. It tells you exactly what to give, how to give it, the dosages and everything. So you just follow that. Warfarin, as you all know, is a vitamin K antagonist. The initial dosage of warfarin is based on the prothrombin level, so you take a blood level, and then based upon that you give a warfarin dosage, but usually it's about 5 to 10 milligrams. There's a performer that we use in Leeds, and there is a different trust, and that's it there. And it tells you exactly how much to give based upon their INR. And then you measure the INR every 24 to 48 hours over the first few days. And then when someone's been on warfarin quite a while, it's usually every 12 weeks. So you can treat anything between sort of 4 weeks and 6 months for a first-time PE, depending upon the cause. If there's no cause identified, it varies then. If you suspect that there might be something else going on, like a cancer or something like that, you might want to investigate that, or maybe undiagnosed thrombophilia, like we were saying earlier. They're important things you might want to consider before you discharge a patient, like that.
Especially on warfarin, we don't actually tend to put patients with malignancy on warfarin.
There's other oral agents on the market. These are usually used in orthopaedic surgery. Again, you don't need to remember the names of these, but you can have a read of them if you want to. So what you need to do from your point of view as an FY1 before you discharge a patient on warfarin, make sure they've got a yellow book, which you'll probably all see. This is really good. It's got everything in it that the patients need to know. You need to make sure you counsel them on warfarin. You need to mention about the risk of bleeding, how there's certain foods that they can't eat, so things like leafy green vegetables, things with vitamin K basically.
Grapefruit.
Yeah, they can still have it to a certain extent. It's just that you wouldn't want them to have it every single day, 3 times a day. Make sure they've got a warfarin clinic appointment within 72 hours of discharge. Like I said before, if you haven't identified a cause, you probably want to screen them for things like thrombophilia and cancers. Cancer, do a CT. Thrombophilia-wise, probably speak to haematology and see what tests they would like.
Especially just for warfarin clinic appointments, I didn't realise until like 3 weeks into the job, if you send patients home without a booked warfarin clinic appointment, it's actually an IR1 of an offence. Just to let everyone know, because no one ever says anything. Okay, so we just have some cases. So you're the FY1 on call, and you're really busy, as always, and you're beat by one of the nurses saying that Mr. Redleg has come from A&E. He's got a diagnosis of cellulitis, he's got some antibiotics going, and he's in a lot of pain because he's complaining of this leg. Can you come and review him, or just come and write him up for some program analgesia because he's really unhappy? Okay? So what are your guys' thoughts about that?
Is it definitely cellulitis?
So, given that it's a DVT and PE presentation, it's obviously not cellulitis. But yeah, no, you're exactly right. It's really easy to just go, yes, the diagnosis of cellulitis has been given, let's just treat some analgesia. But if you're not sure, you should also have a good read through the notes and just double check with the patient. It's better. So yes, and really patient take an ABCD approach, even for little things, because it does actually help. Okay, so you arrive, he's talking in full sentences, mainly about how painful his leg is and how no one's treated him for it yet. So his respirate's fine, he's saturating nice number of air, he's got bilateral air entry, you're not concerned about this patient from a respiratory point of view. Okay, so blood pressure's alright, heart rate 100, what do you guys think of that?
Pain.
He's in pain.
Yes, it's a little bit tacky, which could be explained by pain or could be explained by PE, although saturations and respirate not fitting in at this point, but could be. Okay, so a glucose is done, amazingly, it's fine. So he's on IV fluvoxycillin, it's very swollen, very tender, it's really red, and the guy's in a lot of pain. What are you going to do?
Analgesia?
Yep, analgesia definitely, guy's in pain. You got any other thoughts at this moment? Yeah, I'd definitely do a roll score, or just at least flick through the notes and just see if anyone else has considered the possibility of DVT. So you have a look in the medical notes, which have just been put together, and everything's photocopied from A&E, and half the pages are photocopied on and half off, and the pages are missing. You can't actually make out a decent history and investigation plan, which is not unrealistic at all. It often happens. Okay, so anyway, you decide that you're going to do a well score on this patient just for your own peace of mind, and it comes back as 4. What are you going to do?
Ultrasound scan.
Yeah.
Done.
Yeah, exactly. Okay, brilliant. So you get an ultrasound scan and it actually confirms DVT. What would you do next? You should all definitely get it now. Okay, you treat him with tinzaparin, or and start warfarin. You stop the fluvoxycillin, or if you're really concerned, you can draw a mark around it, which if someone said cellulitis should already be there. Okay.
Second one. So you're working in A&E and you're really tired, and the triage nurse comes up to you and says, "Oh, this man, Mr. Unhelpful, he's just feeling really rubbish and he's a bit short of breath. Can you come and review him?" So what are you going to say and what are you going to do?
What are his observations?
Yep, so you probably ask that, wouldn't you? So I suppose when she said, it's a bit tachycardic, SATs are like low 90s, heart rate's about 110, blood pressure's about 110 over 60, so it's not too bad. GCS is 15. I've done a glucose as well, and that's fine. It's a little bit high, but it's okay. What would you do then?
Take a history from him.
Yeah. So if you could, you would. But if you went to see him, flashed it up there, so you would probably do that magic algorithm of yeah. So maintaining his airway fine. He's speaking, but I wouldn't really say he's completing full sentences. It's got a respiratory rate of 32, but SATs aren't too bad, they're 92%, but he is on 2 litres of oxygen. When you listen to his chest, he's got reduced air entry in both bases. And on his ABG, he's a bit hypoxic. There's nothing else. It's not like he's got a raging acidosis or a high CO2 or anything like that. It's just got a very low PO2, not very low. Does anyone know what the normal range for PO2 is?
About 10 less than the amount of oxygen you're on.
Yes, it's about 10.6 or above. But that varies depending upon the patient. Someone with chronic COPD is probably a lot lower than that. So, like I said before, in all situations, 15 litres, no rebreathe. See if we can get them SATs up. Because if I told you he was a man who had chronic COPD, target SATs are 88 to 92, you'd be really happy with that. But if I tell you that he doesn't have COPD, then we want to get that up to the bit. Cardiovascularly, he's a bit tachycardic. He feels quite cool, but at the moment his capillary refill is normal. Blood pressure's holding okay, but it might be you'd need to find out what his usual is, because if his usual blood pressure is 170/100, then that's hypotensive for him. GCS is 15, blood pulse is 6. When you examine him though, you find that his left calf is swollen and tender and red. And you ask him about it because he hasn't volunteered that information. He says, oh yeah, it's been like that for a while. So what are you going to do for him? Yeah. So like you said before, take a history, so it's just nothing really that interesting on his history apart from the fact he's got inflammatory bowel disease, which is a risk factor for DVT. Do some investigations, speak to your seniors. You do a well score, which comes back at 4.5. So what are you going to do?
CTPA.
Fantastic, CTPA immediately. And then you're going to start therapeutic TINs. And then what would you start after therapeutic TINs if you confirm that it's PE?
Do you start with simplifying before you do? You order the CTPA, you just start with simplifying.
If someone's got a clinical suspicion of PE, you always start with fine. You can always stop it if
Yeah.
the CTPA is negative. It's much worse to send them down without anything supply at all, and then it can turn into massive PE because they could run the clot in the time they've gone down for the scan.
You look at the guidelines and they say immediately do a CTPA before you start treatment. But in reality, like who's going to be next to a CT scanner? No one. Even an A&E resource. It's still going to take them time to do it. So you're much safer to just give them one dose. That's not going to kill them. But a PE might.
The only patients that they'll do an immediate CTPA in, and I mean like within the next hour or so, will be the hemodynamically unstable ones, or the ones that for whatever reason can't come to the car. They'll be the only ones that they'll do really acutely. And even then, there'll probably be a good half an hour delay whilst you take it down, torches are carbon. Takes a while.
If there is well scores, would we be expected to be able to work out the score off the top of our heads, or do we just have to know about it and know
No.
what score
I
we
think we just need to know that we've used the well scoring system, and it would be really useful to know of high risk factors.
How quickly do you start the warfarin? Just as soon as you know that as soon as you know it's positive in CTPA,
Yeah.
then you just start it.
Yeah. So within a couple of days, you don't need to start it that day because once they've had the treatment dose TINs, they're usually fine. So the next day or you should be fine too. Okay, so that's fine.
So, with the FO1 in respiratory medicine, and you're on your normal walk around doing your jobs, and you notice that one of your patients is band lungs, that's original, is slumped over in bed, which is not looking too good.
Actually happened to me.
Yeah. Okay, so what approach would you take? I know it's repetitive, but it will get through the OSCE, believe me, and FY1. So, okay, A. So, she's got an airway, which is a bit easy. She's got her ventilating mask on her head, but will be doing her a lot of good. So, you're going to do the logical thing, sit her up a bit, put the ventilating mask on. She sounds a bit better. But she's a ticket neck, she's hypoxic, and she's on 28% oxygen as well. Have a little listen, she's got crackles in your right base. Your ABG, pH 7.4. Would you guys go for a pH of 7.4? Yeah, it's fine. pH of 7? Yeah, it's hypoxic. CO2 of 10? Bicarb, 32. Yeah, it's raised. Okay, so she's got chronic type 2 respiratory failure. So you put her on 15 litres initially because even though she is type 2, she retains. She's still hypoxic. Hypoxia will kill quicker than hypocapnia will. Every time you do an ABG, always write down the amount of oxygen they're on. Because if you see an ABG in the notes that says pure 2 of 12, it means nothing, because there could be 100% oxygen, in which case they're really hypoxic. So blood pressure is 90/60, so a bit hypertensive, a bit tachy, and they're catheterised, and they've only put up 30 mils of urine in the last 2 hours. Okay. GCS 14, so she's dropping 1. Where's she dropping? 1 point. Yes, alright. Okay. She's got a glucose of 4.5, which is a little bit low, but not too bad. It's always told 4 floor, 5 to drive glucose. So, on examination, she's got varicose veins in her legs, and she is currently on antibiotics because she's been treated for pneumonia. She's known COPD. She's got some risk factors, as you can see. You look at the drug chart. She's not on any tinzaparine or noxaparine at all. No prophylactic anticoagulation. So you do the basics: blood, chest X-ray, which confirms what she's been treated for, right basal consolidation. An ECG shows a right bundle large block and T-wave conversion.
An old ECG at the new.
Yeah, always compare an old and a new ECG, definitely, if you can find one.
And what do you think you do?
Well score. Okay, so you do a well score, which is scoring 3, so just less than a 4. So do your D dimer. Plus. Yeah, always involve seniors early. You'll never get told off for asking your senior something if you're not sure. It's much better than to not treat the patient properly. So, seniors, what's that say? Read CTPA and starting heparin.
Does anyone know why heparin in this case, not low molecular weight heparin? Yep. Yep. CKD. Last case. So you're researching for FY1 and you bleep by the nurse and she says, "Doctor, this is clocked, who's 42 and in bed 1, she's just desaturated to 85%. Please, 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 can you go and review?" And you get the obs and you think, I probably do need to review it. So you do, yet again, ECG, yeah. So we're always hating, but she's actually really struggling. So she's not choking, she can speak, but she's really struggling. So you sit her up and you give her the magic 15 litres. Tachypneic, sats are 85, you listen on the chest, you can't hear anything. It's not a silent chest, she has got breath sounds, but they're just not very exciting. She's a bit hypoxic on her gas. What do you think of that? Blood
Is that
pressure?
gas on her oxygen?
Yeah. Not on a 15 litres, just on like 2 litres. What do you think of that blood pressure and that heart rate? And the fact that she's only passed 15 mils in the last 4 hours? It's quite shocking, isn't it? I would say she's hemodynamically unstable. So I bring in my seniors at this point. GCS is 15 mils, so she's managing to not be too confused at this moment in time. In her history, she's 3 days post-op for a bowel resection for a cancer. She's also on the oral contraceptive pill. Get help. What do you think we need to do in this case? Yeah, prophylaxis. So you do this, and she's got S1Q3T3. So she's probably going to have a poor prognosis. But you do a well score anyway, because you think may as well. And it's 7. Discuss with seniors, like we said, thrombolysis.
Especially that thrombolysis can only actually happen on either HDU or ICU or in respiratory. There's a special kind of critical care unit called RCU. So you can't thrombolyse somebody on a ward. It's actually really dangerous, obviously, because of the high risk of bleeding.
This is the last slide, and we just thought we'd put it in just because we're not sure if you actually ever get any teaching on this, but it's just a little bit on prophylaxis and what to actually prescribe when you are the FY1. It's very important. Everyone should get it unless there's a reason why they shouldn't get it. So if you've got some sort of bleeding from like another GI bleed or ulcers or something like that, or some sort of coagulopathy, or they're under haematology or whatever, but it should be pretty clear if they don't need it. And even then, there's certain things that you can do. It's specific to every trust, and we put in for like Leeds because that's what you'll need to know for finals. So in Leeds, this is the risk assessment that you do, and it's very easy and straightforward. It tells you what to tick and where to tick it. You do that initially when they come into hospital, and then 24 to 48 hours later they need a review on that. So quite often they might do it in A&E or an MAU, and then when they come to you on the ward. You just need to review it.
You'll spend a lot of time filling these out as
Yeah.
well, so it's worth just picking one up before you start work and actually having a good
just
look through it.
Depending upon risk, it's 3,500 to 4,500 units. But usually, as a general rule, pretty much everyone gets 4,500 units. And that's just once a day on an evening, subcut injection. If they're renally impaired or they're over the age of 75, renally impaired, 20 milligrams of enoxaparin subcut. Or if they're over 75 and renally impaired, 20 milligrams. If they're fine, if they're not renally impaired but they're old, they're just over 75, 40 milligrams is fine, but you still give enoxaparin. And if they're under 40 kilos or over 100, then you do it by weight, and it's 50 units per kilogram.
So for like OSCE purposes, I don't think you'd be expecting to know the actual dosing. I think you just need to know tinzaparin and renally impaired enoxaparin.
We just put that in because you can have a quick look at it before you start your FY1 jobs. That's it.
Teds, stockings, blowtons. Everyone should have them unless they've got a reason not to. So unless they've got peripheral arterial disease, that sort of thing.
Are there any questions?
What?
Blowtrans, they're like, so you've seen the TED stockings that are horrendous to put on.